Alright guys, let's get into pelvis, hip, and femur. I'm going to go over standard imaging, trauma imaging, especially this time of year. You're going to see a lot of people coming in a lot of pain, and you're going to have to know how to get good images while also keeping these patients stable. So let's get into it. Here's a good example of a pelvis x-ray. We have our iliac crest at the top of our image receptor, proximal third of the femurs at the bottom. Good marker placement here out of the anatomy of interest. This is what it should look like when you got your patient on the table. As you can tell, the feet are rotated in 15 degrees, and there's a reason why. Let me show you. Femoral necks angle 15 degrees posteriorly to the body. You can see a good representation here in this model. So by rotating the feet in internally 15 degrees, it's going to put these femoral necks nicely in profile. So you might run into this from time to time. This is a repeatable image for a couple different reasons. The big one here, obviously clipped anatomy on both sides and the iliac crest up here. But you can also tell it's rotated for a couple of different reasons. The iliac wing is much more flattened out on the left side here versus the right, where you can see it's clearly foreshortened. Not just that, but the obturator foramen. This one on the left side is much more closed off than this right side one. This is clearly rotated more towards the left. The left side is down. This side is lifting up. They might be hurt on their right side and kind of getting off of that painful point. So just be aware of that. Look for this in your x-rays. So if we have to repeat this for the clipped anatomy, we might as well fix the rotation while we're at it. Okay, look at everything that you can fix. Technique, everything. Taking that into account for our hip x-rays, you could see here the internal rotation causes the lesser trochanter to almost be completely hidden. And that's what we want. We got our femoral neck in profile, nice 15-degree internal rotation. So here's what our collimation should look like on Shannon's hip here. And you can see what it's going to look like if you had x-ray vision. Now when we go to our frog, you can see it's a 45-degree angle of the knee, but the pelvis stays completely supine, flat to the table. We do not want to roll them up onto that hip of interest. We want to keep their butt flat on the table and just rotate their leg out by 45 degrees. Bend the knee so the foot is flat when you do this. And what we're going to see is the lesser trochanter nicely in profile there. The greater trochanter will kind of fall into this space right here if you over-rotate it. So be careful about that. But this is what we should see, a nice view of that lesser. So every so often in the emergency room, you're going to get some people coming in with some bad traumas to the hips, the pelvis area. They're going to be in a lot of pain, screaming, yelling. You just have to kind of put that aside, understand that you're here to help this patient. Your good technique and imaging is going to help diagnose everything that's wrong with them. So be very cautious when handling patients like this. Do not move them. Here's some ways around that, especially for the cross table, to get that done. For now, we're going to assume that this patient has just one leg that's hurt, their left leg. So you can see I have the right leg up on a stand. We have different types of stands that we use, but the foot is going to be out of the way so we can get our beam underneath and just get to that one hip of interest. Okay, and you can see here the patient's holding the cassette. You don't necessarily need to have them do that. I would just use the plate holders that we have. Makes it a lot easier. can see 40-inch SID, that's what we want. And you see here 15-degree internal rotation if possible. That's if they're able to do that. All right, just kind of take every patient for what's in front of you. A little trick to be able to do that is when you have this opposite leg here, if you frog it out to the side, if they're able to do that, it almost puts this leg into that 15-degree internal rotation that you want. And it also gets the soft tissue from the opposite leg out of the way a little bit better. So as long as you're not rolling them up onto that hip, if you do it like a normal frog where they're completely supine like this, that's important, okay? And you're gonna get a really good image without soft tissue getting in the way. So going back to our cross table picture here, you can see they did a great job of getting the opposite leg out of the way. The soft tissue is almost completely out of the acetabulum there. And it looks like they have a good 15-degree rotation internally, because we see our lesser trochanter nicely in profile. The greater is hiding back there, barely poking out into that space. But this is what we want to achieve almost every time we do a shoot through hip. All right, so using what you've learned now from hips and what you've learned from knees, you guys are going to use that to get your femur x-rays done. Okay, we're going to put, for our proximal end here of our femur, for the AP, 15-degree internal rotation, get that femoral neck nice and in profile. And we're going to put the top of our light field we want it right above the acetabulum there. Okay, so if you need to feel for their greater trochanter there to get that picture, that's what we're going to end up doing. But we want the top of the light field there, and we're going to get down as much as we can. Hopefully we can get it all in one picture, but a lot of the time you're going to need two pictures to get this done. And when you do, for the distal end, you're going to take off that 15-degree of rotation, get the kneecap straight up in the air there, the patella. And it's okay to get a lot of overlap here because there's no reference point on the femur to tell the radiologist that you have overlap, unless they have like a piece of metal or something embedded in them. There's nothing there that's going to tell them that you got overlap. So it's okay to get a little bit extra here, just like they did in these pictures. I'm okay with that. And you can see the good marker placement there. And on the laterals, you can see here this person did a good job of keeping the patient supine and frogging out the hip. We have a nice view of the lesser trochanter there. And you can tell they're supine because of the obturator foramen here, still in profile, looking like it does on a supine pelvis. Okay, you would see this start to close off if you angle them towards the table. Now, this end here of the femur is going to be foreshortened because it's going to be pointing up towards the tube, which is perpendicular to the image receptor. In order to eliminate that, for the distal end, we're going to then lay them down all the way close to the table, okay, to get that knee nicely in profile there and with no distortion on the distal hap. Now you can see here we have a bad trauma. Okay, we have a big break, middle of the femur. Not going to be moving this patient a lot, but we're going to do what we can on the femur, just like a shoot through hip, to get the opposite leg up out of the way. We're going to get as much of this femur as we can on this picture, kind of get this end of the acetabulum up towards the edge of our image receptor here. Okay, and you can see how magnified this gets the further down it gets away from the image receptor in this scenario. And on the lateral, this is a different picture, different break than this top one here, but you can see on the distal end we're going to end up doing a shoot through, almost like a shoot through knee. And again, get a ton of overlap as much as you can there. Get as much of that break and fracture as you can to give the radiologist enough to work with. And you can see the epicondyles aren't lined up, but it's okay. You're just doing two pictures 90 degrees from each other. To always get help from a technologist when you're handling patients like this as a student. The more hands you have in the room, the better. All right, last but not least, we have our technique chart. So here you'll see most of the techniques for everything we just learned is pretty similar, okay, with the exception of the trauma hip, that cross table. You're going to need a little bit more mass, 30 to 40, 80 to 90 kVp, mostly because of the unaffected leg, and a little extra distance you might need because of some OID or what have you. So keep that in mind. You're going to need a little bit more mass for these post-op pelvises, you know, when you're going to do a low pelvis here, and there's going to be hardware there, so that's going to create scatter. So keep that in mind. A little extra mass will do you some good. For everything else, you can AEC. Just make sure you're selecting the correct cells. If you're doing a pelvis, do the outside cells. Femur and hips, do the center cell. Okay, 70 to 80 kVp will work great. So practice this stuff. Practice, 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 and come to me with any problems that you have.